share our goal. Okay, we do want to share our goal, and I want to acknowledge for those folks who have been with us for several years on the coin project that we've been working to update our language to be more inclusive. And so our goal statement is that this preconception coin will develop, implement, and disseminate a person-centered, clinician-engaged, community-evolved approach to the preventive visit to improve the preconception health status of people of reproductive age, particularly low-income people and people of color. As I mentioned, we're really excited to have Dr. Spielvogel with us today. He is a practicing family physician in Sacramento, California, and is faculty for the Sutter Family Medicine Residency Program. He is actively engaged in multiple projects relating to preconception, interconception, and maternal health, and additionally has been practicing transgender medicine for the past 6 years at UC Davis School of Medicine and local nonprofit organizations. So we're going to have a quick transition to allow Dr. Spielvogel to start sharing his presentation. And again, thank you all so much. One thing I will mention is if you have questions throughout, I'll keep an eye on the chat, but please do just chat in questions along the way and we'll have some time for Q&A at the end. And I'm sorry to cut you off, Ryan.
Oh, no. I was gonna say, I realized that intro is slightly misleadingly worded. At my institution, meaning Sutter, and at UC Davis School of Medicine, and over at local nonprofits.
Oh, thank you.
LGBT Center of Sacramento and the Gender Health Center of Sacramento is mainly where I hang my hats. All right. Thank you everybody for joining. I am going to share my screen. Okay, everybody seeing that?
Yes, looks good.
Excellent. So today I'm going to talk about transgender sexual health. And so mainly because this is a topic that we don't talk about often enough and can be a little tricky in some points. People get a little confused about language and about assumptions. We make a lot of assumptions in healthcare that we probably shouldn't. And I wanted to talk about not just transgender sexual health, just the actual sexual health, but a lot of these kind of sexual health adjacent topics like safety in the transgender population that really do need to be addressed. So first, let's talk about, we'll just kind of start with, why does this matter? So it's been estimated that 1 to 2% of the US population is transgender, and that's the adult population. And this number is probably, that's probably an underestimate because this is based on surveys and not all people feel comfortable coming out on surveys if they're not out otherwise. And there's a much higher prevalence of morbidity, and sometimes it's very high in this population. And we'll get to kind of where those higher prevalence of morbidities are. And a lot of that is on us. So there is a lot of evidence out there that transgender patients face discrimination, whether it's overt discrimination from healthcare providers. I can't tell you the unfortunately high number of patients I've had who have come to me and said, my last doctor told me that they don't treat people like me, or, you know, things like that are just heartbreaking to hear. And those patients, it took a lot for those people to then try to re-engage with healthcare to say, well, maybe it was just that doctor, or maybe it was just that doctor's office or institution. A lot of them instead just say, forget that. I'm not going to see a doctor anymore. I'm done with that. And then they end up suffering in silence and have a lot of healthcare issues that end up not getting met because there's that distrust and disconnect, well-earned distrust with the medical community. And even when it's not overt, there's many microaggressions that we tend to commit against the transgender population. somebody's up at the front desk and they're dead named in front of everyone. They're called their legal name instead of their preferred name. And people, they sense that everybody else in the waiting room just heard that, and they don't want to engage in care where they feel like the doctors or doctor's office isn't respecting them. So a lot of this is on us. So let's just first talk about some terminology, because language matters quite a bit. And first I want to dispel some notions here. So a lot of these issues that we have with assumptions that we make comes from what I've outlined here, sort of assumptions that sex, gender, gender expression, and sexual orientation all line up, and they do not. They line up for a lot of people. There are a lot of cis hetero people out there. The majority of people are cis hetero, but especially for our transgender population, these things do not all line up. And so assumptions that we make really hurt us in the long run. So sex is commonly defined as your sex assigned at birth in terms of your genitalia. Gender is a social construct. So that has to do with the societal roles that people have placed on people that is oftentimes based on their sex assigned at birth, but it's a societal, it's a social construct. And then gender expression is how you choose to present yourself to the outside world. And that does not always line up with somebody's self-identified gender. And I think that also confuses a lot of people. And then last but not least, sexual orientation does not line up with any of this necessarily. So you can be a trans woman and have sex with other women. And so, making assumptions that if you're a trans woman that you're going to be having sex with cis men is also an assumption that is fraught with danger. So just understanding that these are separate things, especially for the transgender population. And I think just understanding that none of those things necessarily line up the way that you might expect goes a long way to helping you treat this population. So what does it mean to be transgender? Someone who's transgender is someone whose gender identity does not line up with their sex assigned at birth. A trans woman, and by the way, this list is by no means comprehensive. So trans woman, otherwise known as a transgender woman, otherwise known as someone who identifies as trans feminine, is a patient whose sex assigned at birth was male and who identifies as a woman. And in the other direction, a trans man or transgender man or someone who identifies as trans masculine is a patient whose sex assigned at birth was female and who identifies as a man. And then gendered non-binary is basically people who don't fall neatly into that male or female category. They don't consider themselves a trans man or trans woman, or their gender lining up with their sex assigned at birth, and it's somewhere else. And gender non-binary is kind of a big umbrella term. And like I said, this list is by no means comprehensive. So people will come in and there's many other terms on this list that you might hear when you're talking with the transgender population. Gender queer, agender, other things that, so just know that there's a lot of terms out there, and it is totally okay that if you haven't heard that term before, to just in a very non-judgmental way say, oh, I haven't heard that before, can you explain that to me, or something along those lines. If you're coming to that patient out of a place of respect and curiosity with this, that you hadn't heard of this particular thing before, they are going to be more than happy to educate you. Okay. So moving on to gender affirming care. What does it mean to provide gender affirming care? So first of all, you don't have to be an expert in transgender medicine to offer gender affirming care. We all should be offering gender affirming care. If this was just reliant on the experts, then your trans patients are never going to seek primary care anywhere. So it's up to all of us. What does it entail? It entails using the preferred name and the pronouns that the patient uses. So, we have a place in our EMR, or electronic medical record, to put in someone's preferred name, that's what displays, and also to put in preferred pronouns so that it's displayed on the banner what that person's pronouns are. I feel like that has helped a lot, but there are still instances where if their name hasn't been legally changed, someone might dead name them out loud to other people, and that's really kind of the what you want to avoid. I also tell my patients that I'm very careful to use their preferred name and use their pronouns in my notes, but that with electronic medical records, while they make a lot of this easier, they also make a lot of this harder too, because they tend to pull in a lot of information, and then providers are very used to just that information being pulled in, and then they don't proofread their notes and the automatically pulled in information. And so you have to be very careful that if it's pulling in somebody's legal name, that it's going to be in there, and the patients now can access their notes very freely. And so if they see that in their notes it's constantly Amanda and she this and her that and whatever, when Amanda is actually Andy now and uses he him pronouns, Andy's going to be very upset when he reads that note. So I let them know that I'm very careful, but I also let them know a lot of this stuff, it's not done maliciously. It's just the computer pulls in things. And so if you see that, please don't be offended, but please also let me know so that maybe I can educate that provider, but kind of giving them the heads up. Approach sensitive topics delicately, but don't ignore it. And I'll get to what topics I'm specifically talking about soon, because healthcare is healthcare, and sometimes that means pushing your boundaries a little bit and making sure that you get all the necessary information so that you as a healthcare provider can appropriately counsel a patient. And then keep in mind that these patients often have trauma in their past and a lot of times in their present. The rate of ACEs, adverse childhood events, in the transgender population is sky high. So taking a trauma-informed approach to these patients is also very appropriate. Screening for ACEs, making sure that they're in a safe environment, because they're oftentimes not. So just keeping all of that in mind. This is how you can really provide gender-affirming care to patients. Okay, so moving on to family planning. So family planning, I'm using this term kind of broadly to just connote preconception care and contraception counseling for your transgender patients. And so much of it depends on who the patient partners with. And again, your terminology matters here. So how do you ask? So when I was in med school, I was taught that when I'm taking a sexual history, I'm supposed to say, I don't want to make any assumptions. So, who do you partner with? Do you partner with men, women, or both? And this was supposed to be, very progressive terminology, or how we were approaching it. Do you partner with men, women, or both? This is how you're not making any kind of assumptions when you ask someone's sexual history. And the truth of the matter is that that terminology just does not give you the information that you're actually trying to get when you're talking with the transgender population. So it feels inclusive when you say men, women, or both, but it's actually not at all inclusive when you're talking to trans patients or about the trans population. And when I say organ inventory, I mean remembering what you're talking about. You're specifically wanting to know what organs are being involved in this person's sex life, because you're trying to figure out how to best counsel them to either get pregnant or to not get pregnant, or get their partners pregnant or not, etc. So, and this goes back to the traumatic aspect of a lot of this. Patients who, especially if they have the genitalia still that they were born with might be very uncomfortable discussing their genitalia or using the terms that we use for them. So if this is a trans woman asking about her penis, she might be okay with that, or she might cringe at that term and have a lot of dysphoria just discussing her penis. And so, saying, I'm going to be asking you some questions about your sex life and your sexual habits. What terms do you prefer I use for your genitalia? And she might say something different that than you're expecting, and then just respecting that. Or she might say, it's fine to call it my penis, and then that gives you permission to ask in that way. You still need to ask, but respect the person and the trauma and dysphoria that they have experienced around this topic. So then I get more frank. Instead of do you partner with men, women, or both, I'll say, do you partner with do you partner with people who have a penis or a vagina, or both? So that I'm talking more in terms of anatomy, rather than men or women, which is more gender. Because if the patient says, I have a boyfriend, and you assume that that boyfriend has a penis, but that boyfriend's actually a trans man with a vagina, you've just totally set yourself up for going down the wrong pathway here in terms of counseling. Because while your cis patients might also have transgender partners, your transgender patients tend to more often have gender diverse partners. So I've seen way more of my transgender patients have partner with other transgender people. And so you really have to ask explicitly this way. And again, getting really explicit. Do you have penis in vagina type sex? Or substituting the personal terms of choice that I previously said, or just asking more openly, what kind of sex do you have, or what type of sex do you engage in with your partner? And then that gets them to give you the answer that you actually want, that you need. Or another way to say this is, if this is a trans man who still has a vagina, you can say, do you have the kind of sex where you're exposed to sperm? Is another kind of way to get at, is this trans man at risk of becoming pregnant from the type of sex that he's having? Do you use condoms? Kind of an important question. Don't leave that question in the dust. And are you wanting to be pregnant, or are you wanting to get your partner pregnant? Because you also don't want to assume. Now, for most of my trans men, the thought of becoming pregnant is like the most dysphoric thing in the universe for them. But that's not true of everyone. Again, you can't make assumptions. So when, don't be surprised if they say, well, me and my partner are kind of thinking about trying. And then that changes the conversation, obviously, quite a bit, because then it becomes, talking about their testosterone and teratogenicity and planning around that is a little bit beyond the scope of this talk. But that's, of course, again, a very important question to ask. Okay, so what do you do with those answers? Can trans men be on birth control? Yes, trans men can go on birth control. So trans men can use all hormonal and non-hormonal forms of birth control that cis women can use. Now, that being said, the thought of going on feminizing hormones, i.e. estrogen and progesterone, for a trans man who has worked very hard to get away from feminizing hormones that are being produced by his body, that thought is also very dysphoric. So I just tried to talk with them about, well, you don't want to get pregnant, so we got to do something about this. And it's worth mentioning that trans men who are on testosterone frequently no longer have periods, but that's not to say that they're not still ovulating. While a trans man still has a uterus and still has ovaries in his body, he can potentially still get pregnant, even if he's not having periods every month. So making sure that they're aware of that while they still have a uterus, they can still get pregnant, and you kind of need to do something about that if you don't want to get pregnant, can help facilitate this conversation. Because there's also a lot of misnomers out there. Well, I'm not having my period anymore and I'm on T, so I don't have to worry about this. So OCPs work, but again, that's very dysphoric for a lot of trans men. IUDs and Nexplanons are a great option for trans men who still have a uterus. Now, again, I've had more success convincing trans men to get a Nexplanon than I have for an IUD, because an IUD kind of necessitates a pelvic exam, and that's a very dysphoric exam for trans men. So the other thing that I just want to say is that I am not shy about giving my trans men a sedative before doing an IUD insertion. I don't generally do sedatives like Ativan or anything like that for most of my procedures, but I make an exception for this because if it's going to help them get through that dysphoric exam, I'll do it. I see a question in the chat. Are there any interactions with testosterone? Does the testosterone dose need to be adjusted if estrogen and progesterone are also being used? So no. Interestingly, there's no real interaction with the testosterone in terms of their transition. Testosterone, when testosterone and estrogen are in the same body at the same time, in terms of the changes that your external body and physique go through, the testosterone wins. So the testosterone just keeps doing its thing as long as they're still taking it. The estrogen and progesterone, however, are kind of meant to feed back on the GnRH, gonadotropin releasing hormone axis, and kind of shut down the cyclical nature of the estrogen progesterone and stop you from ovulating. So the estrogen and progesterone, the small amounts of that in birth control pills, don't interact with the testosterone, and they can continue. It doesn't interfere with their transition. It's more of the thought of them taking estrogen and progesterone can just, they don't like the thought of that. So that's why I've not had very good success with trans men going on OCPs. Okay, so what happened? Okay, trans women. So the flip side of this is that trans women can still make sperm. So we know that going on estrogens long term does decrease testicular volume. It decreases erections and likely decreases the quality of sperm being made. But while you are still making sperm, you can still get your partner pregnant if you are partnering with someone who has a uterus. So your trans women still need to use condoms if they're using their penis for sex. And making sure that she's aware of that, that if she is partnering with someone who has a uterus, she can potentially get that person pregnant if she's not wearing condoms and using that person's vagina for sex. Okay, so moving on. Let's move on to safety. So transgender patients are less likely to seek medical care. And I think I mentioned this before, has a lot to do with stigma, has a lot to do with either overt discrimination or microaggressions that either they have undergone themselves or have read about. By the way, it's worth noting the transgender population is a very well-read population in general. There's so many blogs out there and chat groups and various other things that there's a lot of it's a very interconnected group of people. And so if somebody has had a really bad experience at the doctor's office, and someone else reads about that, it can really put them off to care even when they themselves haven't experienced it. So let's talk about healthy sex, and specifically sexually transmitted infections. Okay, so this is the importance of a thorough sexual history again, because you need to know it. In order to know what to test, you need to know where to test. HIV and syphilis, as you know, are present in the blood. They're bloodborne illnesses. Gonorrhea and chlamydia, on the other hand, are local infections. Unless someone has disseminated gonococcal disease, you got to know where to test in order to find that it's there. So the way that I usually discuss this with patients is I'll say some version of that. So HIV and syphilis, we test for that with a blood test because it's present in the blood. Gonorrhea and chlamydia, I test you where you've been potentially exposed. Your options are the mouth, the anus, and the urine, i.e. your genitals. I can test all three of those, or I can test whichever ones you want me to test where you've been exposed. Where would you like for me to test today? And kind of give that over to them to decide, so that they say, okay, we should probably test the urine and the mouth today, so that they're, allow them to make that decision, that call for where they've potentially been exposed. Or another option is to just automatically tell them, I do 3-site testing here, so we're going to test your mouth, your urine, and your anus for gonorrhea and chlamydia, unless you tell me that you don't want one of those sites tested or haven't been potentially exposed there. So it's kind of just normalizing it that you do 3-site testing. And this is becoming much more standard at a lot of places that treat the LGBT population. And you really, by the way, I want to take a step back from LGBT for a second. You shouldn't make we shouldn't be making assumptions of our cis population or our heterosexual population either about where they're having sex or how they're having sex. So this should honestly be kind of standard across the board. I can't tell you the number of times that you just, electronic medical record just plops in when you do your STD panel, gonorrhea, chlamydia, urine, HIV, HIV and RPR, which is screening test for syphilis. And that's it. And so that's your kind of STD panel. And then the patient comes back to you months later with this chronic sore throat that just, they're strep negative and they just have this chronic sore throat, and you test them and sure enough, they had gonorrhea or chlamydia in their throat. And it's like, lots of people have oral sex out there. You need to be testing gonorrhea and chlamydia of the throat if you're testing it anywhere else. And not making assumptions that people aren't having anal sex either. So 3-site testing, honestly, across the board, but even more so in your trans population or LGBT population in general. Moving on to HIV. So there is a really high prevalence of HIV in the transgender population. So 3% of trans men live with HIV. That is a high number. 14%, 1 in 7 trans women live with HIV. That's a huge number. And if that was shocking, this is going to be even more so. 44% of trans women of color live with HIV. That's huge. That's astronomically, unbelievably, shockingly huge. So this needs to be a conversation with your patients because HIV is very prevalent in this population. We'll get to why in a second. So when we talk about the transmissibility of HIV, it depends very much on what kind of sex somebody is having. So in order of penetrative vaginal, meaning like a cis hetero man, to receptive vaginal, to penetrative anal, to receptive anal, your risk of transmitting HIV to someone is 1 to 2 to 3 to 35. So someone that engages in receptive anal intercourse is way, way, way more likely to catch HIV if their partner was unknowingly HIV positive. And so this is one of the main reasons why trans women, and I don't entirely know why the disparity there between all trans women and trans women of color exists, but this is a lot of the reason why trans women in general have a much higher risk of contracting HIV. Along with this, so there was a study done where they compared trans women, this was done via survey, trans women to men who have sex with men. So, and compared their habits to one another. And they found that trans women were much more likely to engage in condomless anal intercourse, much more likely to engage in survival sex. And when we say survival sex, another name for that is transactional sex. So this is either sex work, but not necessarily sex work. This is also potentially like, you know, exchanging sex for goods or sex for rent or something like that. That's commonly referred to as survival sex. And trans women were more likely than men who have sex with men to have more sexual partners in the last couple of months. So all of this kind of, plus the fact that receptive anal intercourse is, you're much more likely to contract HIV from that, kind of leads to this very lopsided disparity in where people are contracting HIV, what people are contracting HIV. And so this leads me to the importance of PrEP. PrEP is pre-exposure prophylaxis. This is a pill, one pill once a day, either Truvada or Descovy. These are both antiretroviral medications. Truvada is they're combo of the same medication. Descovy has a long-acting version of one of the antivirals in it compared to Truvada. Truvada is an older medication. Descovy is kind of the newer replacement of Truvada, sort of. And pre-exposure prophylaxis is basically where you're taking either Truvada or Descovy, one pill once a day. And if you have that on board, you are much, much, much less likely to contract HIV if you are exposed to it. It dramatically reduces the HIV infection risk from sex. It does also reduce the HIV risk, HIV infection risk for injection drug users as well, but it's not quite as good there. It's more like 60 to 70% efficacy for injection drug users. When we're talking about HIV infection from sex and sexual practices, it's more like in the upper 90s effectiveness at preventing HIV if somebody is compliant, if they're actually taking it, adhering to it. It's important to note that this does not treat active HIV. So if somebody does contract HIV or has HIV, they can't take just Descovy or Truvada. That is part of an active HIV regimen, but that by itself does not actually fully treat HIV. So how do you administer this? How do you talk with your patients about it? How should they be taking it? How do you start it? So you have to test for HIV before you start PrEP because they need to be HIV negative if they're taking PrEP. Hepatitis B is also partially treated by either Truvada or Descovy. And so you have to, but if they take Truvada or Descovy and they have hepatitis B, chronic hep B, and then they go off of the Truvada or Descovy, they actually get a big flare of their hepatitis B and can go into hepatic failure from that. So you need to also make sure that they don't have hep B before you start treatment. I test for HIV every 3 months and prescribe a 90-day supply after that. So I test for HIV, I give them a 90-day supply of PrEP. And then when they're running out, so I tell them, about a week before your prescription's out, shoot me an email. I'll put in another STD panel, including HIV. And then when your HIV comes back negative again, I'll leapfrog it. And I basically do this. So 90 days, HIV test negative, another 90 days, HIV test negative, another 90 days. This is not something that you should be doing 90 days with a bunch of refills on, because you really do need to make sure that they continue to be HIV negative. Because it's going to be a lot worse if, say, they weren't the most adherent with their PrEP regimen, and then they end up contracting HIV, but they're still taking their PrEP intermittently, and then they've just made resistant HIV. That's going to be much harder to treat for them. So you do need to be very accountable for this. So the PrEP regimens that we have, Truvada and Descovy, can rarely cause renal impairment. And so you do have to test their renal function. So their creatinine and microalbumin urea, checking that every year. So the benefit of Descovy over Truvada is that Descovy has fewer renal effects and also less bone mineral density effects than Truvada did. So I am personally now starting all my patients who are starting PrEP. I start them on Descovy. I'll bring it up to my patients who have been on Truvada, but if they like their Truvada and they don't want to change, I don't push it. As time goes on, I might push it more and more and kind of eventually get everyone onto Descovy. But a lot of people equate PrEP with Truvada at this point, and hey, it's better than nothing. So I'm going to continue that if they want me to continue it. And then it's worth mentioning on-demand PrEP. So this is something that your patients might be doing and then just not feel comfortable telling you that they're doing it because they've read about it and they read that it's effective, and they don't want you to judge them or take away their PrEP, and so they don't tell you that they're doing it. So PrEP works really, really well as long as you have Truvada or Descovy in your system when you are exposed to HIV. So it is not post-exposure prophylaxis, meaning you didn't have it on board, you had unprotected sex, and then you take it. You've already been exposed potentially at that point. You can't use it that way. But if you are having infrequent dalliances and you are wanting to prepare and you think, okay, I'm going out with so-and-so on Friday night, and I'm probably going to have sex with that person on Friday night. So you can plan ahead, and if you aren't having a lot of intercourse where you feel like you need to be on PrEP all the time, you can instead plan ahead, say, okay, Friday night, I think it's going to happen. So on Friday morning, you take 2 of your Descovy so that it's in your body it's kind of a loading dose, so that when you have your exposure, potential exposure, it's already there and protecting you. And then you take 1 pill for the following 2 days after your last intercourse. So if you just had sex on Friday night, you would have taken 2 on Friday morning, 1 on Saturday, and 1 on Sunday, hence the 2-1-1 method. But it's really 1 pill for 2 more days following your last intercourse. So if you had an all-weekend marathon with 1 partner or multiple partners, it'd be 2 on Friday morning, and then 1 on Saturday, 1 on Sunday, and then 1 on Monday and 1 on Tuesday, depending on when your last intercourse was. And then you can go off of it. And it has been shown that on-demand PrEP, when used correctly, again, big caveat there, is highly effective at preventing HIV. So my patients who have 5, 10, 15 partners in a month, I'm telling them they need to be on PrEP every day. My patients who say, I have maybe 1 to 2 partners every several months, on-demand PrEP might be a better option for them because it's exposing them to less medication that they might not actually need, as long as they plan ahead. And if they didn't take PrEP that morning, their loading dose of PrEP that morning, then they just need to be responsible and use condoms. I see another thing in the chat here. Oh, that's not that. Okay. moving on. Healthy relationships. So intimate partner violence is very high in the transgender population. So it is estimated that there's 1.7 times more physical IPV in the trans population, including remote and also within the past year, and 2.5 times more sexual intimate partner violence, both in the past remotely and also within the last year in your trans patients. And interestingly, this is consistent. It's the same in both trans men and trans women. There's not a discrepancy there, which I don't know why I thought that there might be. So really, we screen for IPV at certain points for patients, like in pregnancy, where IPV and the risk of IPV is a lot higher. But your trans patients just in general have a much higher risk of IPV. So it's very important to screen your trans patients at new visits to see if they feel safe in their relationship, if they, with their current partner, and screen them yearly, because this is really a problem. Okay, so moving on to the last topic, sexual function. So this is just recognizing that sexual function can change with hormone use. This is where it's important to kind of recognize somebody's own personal goals for their transition and how they plan on or want to continue having sex, or how they see their transition playing into their sex life or changes in their sex life, and helping to clarify those goals so that you can help them through the various changes that come along with hormone use. So for instance, libido changes a lot. The elevated libido that you are all aware of that exists in cis men compared to cis women is a factor of testosterone. So making sure that trans men know that their libido is going to go up when they start taking testosterone, and for trans women that their libido is going to go down when they start suppressing their testosterone, either through direct anti-androgens or through just estrogen or progesterone, which are both anti-androgenic on their own. There's changes to the clitoris. So testosterone causes clitoral enlargement, otherwise known as clitoromegaly. In the other direction, trans women, when they go on anti-androgens, start having erectile dysfunction. Now, for most of my trans women, that is very much a desired effect. They don't like having erections. Having an erection is a very dysphoric feeling and moment. They don't want it, and so they're very happy when they're no longer able to get an erection. But there are lots of trans women who still use their penis for intercourse and really don't want to have erectile dysfunction. And so that's going to be honestly a conversation between that patient and their hormone provider, whether it's you or somebody else, to make sure that there's a balance being struck there, that the hormone provider isn't going down one path when the patient is actually having some side effects that they don't like from their hormone regimen. And there are ways to get around that, but it just has to be a conversation there. And then if they're planning any surgeries to their sexual organs, and discussing with the patient how sex will be different after they've had a phalloplasty, meaning the creation of a neopenis, neophallus for a trans man, or a vaginoplasty, and how sexual function changes after having a vaginoplasty. A lot of that conversation is honestly going to be on the bottom surgeon, the surgeon who does the phalloplasty or vaginoplasty, but they're going to be dealing with the patient acutely to do the surgery, maybe do a post-op check, something like that. And then it's going to be your job as either the primary care provider or the hormone provider who's providing longitudinal care to help someone through the changes that happen in their sex life remote from their surgery if they're having surgery. And so having a good understanding of vaginal stenosis that people can have after vaginoplasty, and dilating, and the issues that can come up with phalloplasty and urethral strictures and et cetera, can be helpful to the patient who might be having some issues with sexual functioning or having some discomfort with their after their vaginoplasty. And I don't want to just think about people who have had these surgeries. Also beforehand, if you have a trans man who's is talking about trans women and problem erectile dysfunction, but trans women, trans men who have vaginas still can have a lot of vaginal atrophy, because you're essentially inducing menopause a little bit when you're taking away their native estrogen and progesterone. And so they can start having vaginal atrophy, start having pain with intercourse if they're using their vagina for sex. And so being able to counsel a patient on lube, possibly even vaginal estrogen cream, if they're open to that, because that can really improve sexual functioning, and they may have felt uncomfortable bringing that up with you. So I think that's everything I've got. And I think we're perfect on time for questions. And I'll stop my screen share so we can come all back together.
Thank you so much, Dr. Spielvogel. Yes, folks, if anybody has a question, do feel free to put that in the chat. Also, I feel like you should be able to unmute yourselves if you'd rather bring up a conversation point or ask a question, then please do. And we'll just give it a moment for everybody.
And I'll also just throw out there, I didn't mention this to begin with, but providing care to the transgender population is incredibly rewarding. It is some of the most rewarding work that I do, because these patients really feel like they haven't had a medical home a lot of times, which is very sad. And so being able to provide affirming care to this patient population is a wonderful thing. And why it's important to provide comprehensive care.
Thank you.
Hi, I have a question. My name is Erica Rood, and I'm the Chief of Outreach and Education with the Maternal, Child, and Adolescent Health Division at the Department of Public Health. And we are exploring how to provide our public health education materials in a way that is inclusive of the trans community. And we're finding it particularly challenging as it relates to pregnancy intention. What language do we use when we're thinking about creating a healthy lifestyle for somebody who has the potential to get pregnant, knowing that pregnancies are often unplanned or unintended? So any guidance you could provide related to that would be extremely helpful.
Yeah, so again, it is tricky because you might be using terms, if you're either using terms that are somewhat ambiguous or at least very cis heteronormative, so I guess unhelpful terms, or you're using terms that might be too explicit and cause some dysphoria in how you're phrasing it, penis and vagina type sex, for instance. So, if I do think that you still do have to talk about, if you partner with a patient who makes sperm, and you still have a uterus, you could become pregnant. Uterus and sperm tend to be a little bit less dysphoric than penis and vagina if you're talking to the trans population. Again, that's not the case for everybody, but you're right. This can be a little tricky because men, women are both, sort of the previously most progressive way to ask that question. Leaves a lot of room for misinterpretation. Yeah, I think educating that, if you're on hormones, it doesn't, if you're on cross-sex hormone therapy, that doesn't mean that you can't accidentally get pregnant or get somebody else pregnant. And so making sure that you're staying protected and kind of maybe approaching it from that standpoint, because that's the big misconception, is that I'm a trans man, I'm on T, so therefore I can't, and I don't have periods anymore, so I can't get pregnant. Or the other way around, I've been on estrogen forever. It's really difficult for me to get an erection. I've noticed that my testicles are a lot smaller, so I can't get somebody pregnant. And those two misconceptions lead to some conceptions.
Thank you so much. It was so helpful.
Thank you. So there's a couple more comments in the chat. Of course, some appreciation for your information and just and how you've presented. So just thank you so much. One is a question for suggestions or resources about preconception, pregnancy, and postpartum care in this population. Again, so much of the language is gendered and they're pivoting to change that. So if you have any recommendations there.
Inclusive pregnancy intention guide, screening questions, and then yeah. So there's unfortunately not a ton of really great resources out there. I'll be totally honest, generally my transgender population wants nothing to do with pregnancy, most of them. But for the patients who do, my trans men who are, I've only had 2 who were interested in potentially having biological children. And for them, it was discussing that you have to go off of your T for a certain amount of time for us to even see if you are still able to ovulate. And we might have to actually use medications to assist you in ovulating. And they looked into it a little bit and said, never mind, I don't want this. Because they do have to go off of T to do it. And that is a kind of a big deal for a lot of trans men. So, in terms of pregnancy and postpartum care, again, it's very uncommon, because if they do get pregnant, it usually is not a pregnancy that they want to keep. And so that doesn't go much further. I can certainly look into it to see if I can find anything, if Gender Health Center where I work has something, but to my knowledge, there's not like a great information source like brochures, that kind of thing. That might be something that we could develop. I like where this is going.
Yeah, thanks so much for that. We can, and if you do find something for the folks that are on the webinar, we can be sure to link it on our website, or send it out in a newsletter. So just so everybody knows. You have another question. Would it be appropriate to advertise our expanded maternal, child health, and sexual health services as having gender-affirming trained practitioners?
Oh, and before that, somebody said about,
yeah, sorry.
I would love to see examples of inclusive pregnancy intention guides and screening questions. So the ones that we use here, I'll still ask, are you wanting to be pregnant in the next year, or to get a partner pregnant in the next year? And the way that I document that for my trans patients, or for just my LGB patients in general, if they say, I don't have that kind of sex where that can happen, is patient does not engage in penile vaginal intercourse. And that's kind of my blanket way of saying that's not going to happen. And so we don't need to worry about it further. Okay, so would it be appropriate to expand maternal, child health, and sexual health services as having gender-affirming trained practitioners? Absolutely. So we have, it's very much a, if you build it, they will come. If you advertise that you offer gender-affirming care at your institution, you will start seeing a lot of gender diverse patients, because they look for that. Like, people are searching online for that. So you make it searchable, you put it on your website, you will attract more transgender patients because they go to the primary care providers who they know, because people talk, where they'll get a good experience, or where people are always looking for new resources. This patient population is always looking for more places to call a medical home. And it's a very scary thing to go to a doctor and be like, I don't know if they're going to accept me for who I am. or how they're going to treat me, and so rather than do that, they become avoidant. A lot of these patients become avoidant. So if it's advertised like, you don't have to worry about us, we're gender affirming here, absolutely, I think that's appropriate.
Thank you so much. Seeing more appreciation. I know we just have a few minutes left, so if anybody has another question, I'm going to just share my screen for a moment and just want to have this up. The evaluation link, I've also put this in the chat, but if you could share feedback, that would be really wonderful. You could just take a moment to complete this brief survey. Again, our social media properties for connecting with us and staying connected. If you haven't received our monthly newsletters, please do reach out and let us know. Happy to get those sent out to you and get you signed up on the listserv. And of course, we want to appreciate our fun. So thank you. And I saw one more chat. Let's see if it was another token of appreciation. So I will applause. Thank you very much.